nice pictures, everybody.
All right, so we should be good here. And we'll give it a couple more minutes and then we'll start. Okay, so we'll kick off in about 1 minute, and as we get started, this is our second ASHNR Temporal Bone Case Conference. I'd like to warmly welcome our panelists and say thank you to all of our participants from all over the world, including those who are staying up way beyond anyone's normal bedtime. And this is a very informal case conference, and we welcome those of you who are attending to join us with your chats. I can already see some action over there from Phil Chapman and Ilson. So we welcome conversation and discussion as we go along. Share your questions, share your expertise, and let's get started. And so I'm Kelly Robson, and I am a pediatric neuroradiologist from Boston Children's Hospital. And I'm going to pick up from where we left off last time, considering some topics that were shown by Amy and Bill of labyrinthitis ossificans, some masses, and now to consider the differential diagnostic options for children. And so let's start off with the first case of a 4-year-old male who presented to the emergency department with 6 weeks of otorrhea, otalgia, and 7th nerve palsy. And the initial diagnosis that was made was of persistent otitis media and Bell's palsy. Well, the clinical course of this child unfortunately went on to develop conductive hearing loss and presented again to the emergency department with a preauricular bump and failure of resolution of any of the previous symptoms. The contrast-enhanced CT was obtained, and it showed a pacification of right mastoid air cells and of the right middle ear space, possibly some ossicular erosion. And then looking at the Petrous apex on the right, it appeared demineralized with a rather washed out appearance. And then an important feature was erosion extending to involve the anterior wall of the right internal auditory meatus. Now, this is a structure that is housed along the anterior border of the oticapsular bone and is usually pretty resistant to destruction. As you look at the soft tissue windows, you can see there was enhancement extending beyond the confines of the Petrous apex and also right parotid space lymphadenopathy. And so an MR was obtained, and these are the T2 weighted images, which show a low signal intensity lesion involving the right Petrous apex, extending into the ISC and protruding into the cerebellopontine angle cistern. And as you look here for the etiology of the facial nerve palsy, you can see enhancing lesion extending from Petrous apex along the labyrinthine and tympanic segments of the facial nerve, which appears abnormally widened. And then there is enhancement in the ISC projecting into the CP angle cistern. And the lesion demonstrated decreased diffusivity on DWI with the hyperintense secretions noted laterally. And this was the appearance on otoscopic exam, where the clinicians could actually see a whitish lesion within the middle ear space, which they went on to biopsy. So as we consider differential diagnosis, we'll look at some lesions involving the IAC and Petrous apex. And the differential diagnosis would really be between various inflammatory processes and tumors. So here is an interesting companion case of an infant with identical symptoms, including 7th nerve palsy, and compare and contrast with the prior patient. In this patient, there is again opacification of the middle ear space and mastoid air cells. And as in the prior patient, no evidence of erosion of the septations in the mastoid air cells. So I would suggest, for example, that when you describe this opacification on CT, you can't really distinguish between fluid, soft tissue thickening, granulation tissue, etc. But one thing that is helpful to the clinicians is to say that you don't see any bone destruction. So even if they're considering otitis media with mastoiditis, you would be able to say that there are no radiological features of coalescent mastoiditis. So in this patient, notice that the Petrous apex looks completely normal. But then look at the MR, and these fat-suppressed T1-weighted contrast-enhanced images show asymmetric enhancement of the right Petrous apex in this child, bearing in mind that on CT it's non-pneumatized, and also, interestingly, enhancement within the right IAC, and there's smooth adjacent dural enhancement. If you look very carefully at the cochlea, there's very subtle enhancement in the basal tone of the cochlea as well. So the features here are Petrous apex enhancement without bone destruction, very smooth dural enhancement, normal-sized IAC with enhancement, led us to suggest the diagnosis of tympanogenic labyrinthitis and Petrous apex osteomyelitis. This patient had a tympanostomy placed, was found to have a mucoid effusion which cultured strep pneumoniae. Interestingly, over time and with appropriate antimicrobial therapy, the IAC mass cleared up completely. However, unfortunately, the patient went on to develop florid labyrinthine enhancement, fibrosis, and ultimately ossification. So this was labyrinthitis ossificans, complicating infection. Now, it is unusual, but not terribly rare, to see enhancing lesions accompanying infection, either unilateral associated with tympanogenic labyrinthitis or bilateral in association with labyrinthitis that occurs with meningitis. The key feature is that these enhancing lesions do not erode or deform the canal, and they resolve within weeks of treatment of the infection. Unfortunately, the accompanying labyrinthitis does not typically resolve, usually progresses to ossification. Now, the next question is, do we see bone erosion on CT with Petrous apex infections? Well, in kids, we see two varieties. One is bone destruction due to Petrous apex osteomyelitis, where the Petrous apex is non-pneumatized. Most often when we see Petrous apex infections, the bone does not appear eroded on CT, but will show abnormal signal on MR, abnormal enhancement, and often you'll see spasm of the Petrous carotid. We do also see Petrous apicitis manifesting in a pneumatized Petrous apex as infection, and it is unusual, again, to see flagrant bone destruction in kids. However, this is an example of a pneumatized infected Petrous apex in a patient who had autism spectrum disorder and was not very communicative, so this was a long-standing and neglected case of Petrous apex and central skull-base osteomyelitis. And this is another indolent, long-standing infection of fungal labyrinthitis following cochlear implantation, which led to Petrous apex destruction, otic capsule destruction, and a perilymph fistula. And it is pretty unusual in these infections to see mass-like enhancement, but occasionally that will be seen. So what about a differential for IAC masses? So we've talked about inflammatory disorders. Let's look at some neoplasms. The one thing to mention is that we saw a great description from Amy last week of the differential for vestibular schwannomas and IAC masses in older patients. But in children, specifically under a year of age, if you were to see an IAC enhancing mass, this is most likely attributable to a proliferating hemangioma. And telltale signs are intense enhancement, a vessel leading up to or within the lesion, and you may see other hemangiomas elsewhere. These hemangiomas are often accompanied by other abnormalities as seen in facies, such as posterior fossa malformations, arterial anomalies, cardiac defects, eye and sternal abnormalities. Interestingly, for temporal bone enthusiasts, if you give contrast in the first year of life, you may see an enhancing mass, but subsequently, once the mass has proliferated and been shrunken down again or involuted, you'll be left with ipsilateral widening of the IAC on the affected side with the cerebellar hypoplasia. The other interesting feature is that in patients with this association of these regional craniofacial hemangiomas with a kind of dermatomal involvement or midline or beard-like distribution, as you look intracranially for these abnormalities affecting the cerebellum and arteries, also take a look at the temporal bone, because these patients have a very high incidence of a persistent stapedial artery, as seen here on this MRA. There's a normal middle meningeal artery on the left side going through foramen spinosum, and coursing through the temporal bone on the right is a persistent stapedial artery. Now, what about tumors? Well, we talked about LCH last week, and we talked about the predilection for the temporal bone. Its punched out pattern of bone destruction with a sharply defined transition between eroded bone and normal bone. So this is LCH. But we see other tumors in childhood. So in terms of malignant primary tumors in infants in the first few years of life, should you see a tumor located in the cerebellopontine angle cistern, aggressively eroding bone, consider an atypical teratoid rhabdoid tumor. And then the most common malignancy to occur as a primary tumor in the temporal bone, usually during the first decade of life, is going to be rhabdomyosarcoma. Again, aggressive bone destruction. Metastatic disease is also seen. So these are in the first decade of life, consider neuroblastoma, and in older children, consider leukemia with overlap in the imaging features. Now back to our index case. This child had biopsy of the middle ear space lesion, which proved to be neuroblastoma. So the patient underwent MIBG scanning, which showed positive uptake, and this was a metastatic lesion associated with a left suprarenal primary. And finally, just to round off an interesting companion case, this was a 3-month-old male known to have had treatment for high-risk neuroblastoma. So a year ago, the patient had had surgery followed by chemotherapy, and then 2 months prior to admission had had 2 autologous hematopoietic stem cell transplants. The patient then presented with a week's history of cranial nerve 7 palsy and rapid onset of sensory neural hearing loss. Imaging showed mass-like lesions within both internal auditory meatus, which enhanced, as well as enhancement within the labyrinth on the right. And we gave a very wide differential diagnosis considering all the entities we've mentioned. We mentioned inflammatory disorders, IgG4 disease. We considered tumors, either new manifestations of neuroblastoma or something else. And interestingly, this patient was found to have EBV positivity in the CSF and ultimately was diagnosed presumptively of having post-transplant lymphoproliferative disorder in a patient with neuroblastoma. Okay, so that's my presentation. And so I'd like to know if anyone in the audience has any questions. We'd be happy to answer them as we go along. And I'm going to stop the sharing of my case and hand things over to our next panelist, who I believe we're going to have go presenting.
Sure. Let me just get, where is my, can you guys hear me okay?
Yes, we can hear you very well. Thanks, Gul.
Okay. So this is my screen and I'm sharing it. I'm hoping that you guys can all see my screen. Affirmative? Okay, great.
Affirmative.
Affirmative. So this is our first case, and it's actually a fairly recent case. So this is a youngish female in the late teens who presented with about 7 weeks of off and on vertigo, nausea, vomiting, and clogging, ear clogging. That's pretty much her main history. And then she had a history of minor trauma about one week prior to admission. And then she also sort of developed hearing loss. So sudden hearing loss over the past week. And this imaging was performed, and it was, to clarify, it was sensory neural hearing loss. So let's look at the imaging. So let's start with the 3D flare. You can see, as I'm scrolling through the IACs, that there is increased flare signal in the left vestibule, lateral semicircular canal, and cochlea. Also in the posterior semicircular canal. And on the right, you can see similar signal abnormality in the basilar turn of the cochlea and in the posterior canal. Some questionable signal in other areas, but it's mostly it's not as pronounced on the right side. This is the T1 weighted image pre-contrast, and the right side looks fairly unremarkable. And on the left side, we see that there's increased T1 signal in the vestibule and the superior semicircular canal. Really, otherwise not very impressive. And the post-gadolinium images, there really is it's hard to tell whether there is any increased signal, but if you can see, there might be some minimal enhancement in the basilar turn of the cochlea. But because of the pre-existing intrinsic T1 hyperintensity, it's hard to discern whether that's actually true enhancement or not. This is the 3D gradient image, and you can see that there's a little bit of poor fluid signal in the superior canal compared to the right side. And as we keep coming down, the rest of the study, again, the lateral canal maybe has a little bit of poor fluid signal. So putting it all together, when you see that there is increased T1 signal and increased flare signal, this is fairly characteristic for labyrinthine hemorrhage. And so I'm just going to talk a little bit about that. So let me pull up my PowerPoint. T-bone time.
So Gul, while you're pulling up your PowerPoint, we have a question about your flare sequence. And they wanted to know, what are the parameters for the flare sequence? And Phil Chapman specifically asked, do you use thin/flare 3D IACs?
Yeah, yes.
Somebody else wants to know, is it a 3D sequence?
Yes, so this is a 3D flare sequence, but we also do our regular, 2D, regular flare also. So so we have different, different MRI machines in different, settings. So there are some MRs which actually we're able to get a good 3D flare sequence. So we do that. I know at Mass Eye near on the Philips, there's also a good 3D flare sequence, right, Amy?
Yeah, we just started doing some 3D flares, but we don't rely on that too much, but we do them.
Right. So to answer your question, I think I do 2D flares for the most part in all ISCs, but when I am, concerned for, for like some sort of hemorrhage, I have them run a 3D flare. And also, it also depends on which MRI scanner. Not all my MRI scanners give me a good result with 3D flare. And they all have different names for different, like Philips is going to have a different name. I think it's called Vista or something else. Or so in this case, this happened to be on one of the scanners where we could run. This was, I think, a Philips scanner, and we could run a good 3D flare sequence. This was, so the interesting thing about this case was also the fact that this patient turns out to be COVID positive. I mean, it's presumed COVID positive. She had pretty classic COVID symptoms about a week or actually 3 weeks prior to this MRI. So that sort of makes the case a little bit more interesting. So let's just discuss a little bit about labyrinthine hemorrhage, and then we'll come back to this case. Okay. So labyrinthine hemorrhage tends to be hyperintense on T1 weighted image and hyperintense on flare. Now, there have been a bunch of case reports describing labyrinthine hemorrhage in multiple different clinical settings, most commonly in the setting of hematologic malignancies, leukemia, aplastic anemia. The patients are on anticoagulation, hematologic disorders, a whole host of hematological disorders. Viral or bacterial infections can lead to labyrinthine hemorrhage. There was one postmortem report of Wagoners with labyrinthine hemorrhage, SLE, migraine, multiple sclerosis. I've never seen MS with the labyrinthine hemorrhage, but it's been described. There has been one case report of endolymphatic sac tumor, but I think we've seen a few others at the ASNR meetings where the intralabyrinthine hemorrhage was the first presenting sign of endolymphatic sac tumor. Obviously, trauma, idiopathic and spontaneous. In my experience, this really is the biggest category. We've had a lot of patients who've had, you know, these disappearance, and we get follow-ups, and you know, it's really hard to find any of these causes. So these patients may present with vertigo or sudden hearing loss. Sudden hearing loss is really a pretty classic sign. And there's been one paper which described the natural history of labyrinthine hemorrhage, and they, according to this paper, this resorbs in about 4 months. Although I've seen that these can persist. And just some images. This is from Dr. Shuknik's book. It's a pretty classic book from Mass Eye. Shout out to the folks there. So this is just to show you that there is this patient who had leukemia and has all this hemorrhage in the perilymphatic spaces, as well as a little bit in the endolymph. So this is just a good pathologic description. Interestingly, they thought that the changes and the patient's you know, hearing loss was because of the degradation of the fluids, so the perilymph and endolymph, as opposed to actual change in the hair cell itself. So the hair cells were apparently normal, but it was the abnormality in the perilymph and endolymph, the hemorrhage, that was contributing to the hearing loss. This was kind of interesting when I was researching this topic, that subarachnoid hemorrhage, in patients with subarachnoid hemorrhage, you can actually get blood in the perilymph because there's a direct communication to the cochlear aperture. So, so in this case, coming back to our case, I think this is labyrinthine hemorrhage. I've seen a few cases anecdotally of COVID patients who not just present with head bleeds, but we had a case of a big thyroid nodule which ruptured and presented with retropharyngeal hemorrhage. And then, so I'm wondering that if COVID had anything to do with this underlying hemorrhage. You know, she's getting tested and her dad is positive. So, you know, we'll see how that goes. But I just thought this was an interesting discussion and interesting sort of imaging findings. And then moving on to our next case, let me just get back to my...
Okay, while you're getting back, there've been a bunch of questions from the earlier cases. So there was a question from Shanaz about, just to remind people about what a perilymph fistula is. So that is an abnormal communication between the perilymph containing spaces of the otic capsule and the middle ear space. And it can be congenital or acquired in nature. If it's congenital, it's usually a tiny hole in or around the oval or round windows, but they can also be acquired due to any type of bone erosion or sometimes iatrogenic in nature. Someone else asked about, do CP angle ATRT have parenchymal components? Never seen a case like that. More frequently, these actually occur intraparenchymal tumors, but we've seen now a number of cases involving the extraaxial compartments, including the skull base in and around the temporal bone. All right, over to you, Gul.
Okay, great. So this is my second case. So she's a woman in her late 50s who presented with right ear clogging and crinkling sounds and hearing loss about 6 years prior to admission. And this was a study that was done in 2014. So apparently she'd also had trauma, and there was a history of temporal bone fracture, which we didn't have access to at that time. So we were looking at the temporal bone study as just a standalone without any prior sort of imaging. And in 2014, the finding of note is there's this bony defect in the right anterior wall of the external auditory canal with soft tissue herniating into the EAC. And you can see that it's causing some luminal narrowing of the EAC. Of note, the left side looks completely normal. That bone is completely normal. So she underwent surgery of the TMJ, and essentially she started just having recurrent symptoms. Her surgery, she underwent a titanium reinforced Medpore implant, and there was a little bit of issues during surgery, but anyways, so she essentially has been complaining of, worsening headaches. And so she got a follow-up CT and MR. So first she had a follow-up MR, which I'm just showing you a few images just to give you a sense of what's going on. So these are post-gadolinium images. So you can see that there is definitely enhancing soft tissue corresponding to the abnormality that we saw in the CT, again causing luminal narrowing. However, the other interesting thing is now she's developed on the contralateral side another sort of enhancing area right exactly in the same location. And then, incidentally, she also has an epidermoid, which she post-op epidermoid, which really it's higher up in the ESC. So that's not the focus of my, there it is. That was just an epidermoid that she, was presumed to be post-op. So the more interesting thing was that is clearly enhancing soft tissue there, but she also developed sort of an abnormality on the contralateral side. And now I'm showing you the CT from, done right after the MR. And here, now you can see that she's developed a defect on the opposite side. And there's clearly no history of trauma in the past, 4 years. So this is definitely not traumatic. Although we can assume that the right side may have been traumatic back in 2014. And just to show you the difference between the study in 2014 and 2020. So what are we dealing with? So my conjecture is that we're dealing with bilateral TMJ herniation. So this is essentially a kind of interesting topic, and the more I delved into it, the more I discovered about it. So it's been seen in sort of a lot of normal case series. Bony defects can be seen in the anterior wall, and for example, in this big paper from 2010, they found that it's 2.3% of patients had bony defect in the anterior wall. And so the defects could be related to cholesteatoma, trauma, which we might conjecture might have happened in our case. There's also something called patent foramen Husky, which I'm going to talk about a little bit more. And these patients can actually present with symptoms: tinnitus, clicking, conductive hearing loss, otalgia, otorrhea, or they may even be asymptomatic. So what are the other causes for the defects? I mean, you can get otitis externa, which can result in a defect. There have been case reports of TMJ arthritis, especially rheumatoid arthritis with defects. And so the things that sort of dehisce through the defect could be a meniscus of the TMJ, could be TMJ synovial tissue, or some people have even reported ectopic salivary tissue. And this is just to show you that on the open and closed mouth view, it's going to actually reduce when it's in the open mouth view. And there it is. There's the bump right there. So what is the foramen of Husky or foramen tympanicum? So if you go back to embryology, the tympanic bone is a U-shaped structure. And in the first 5 years, there are these two protuberances that develop and sort of join together to form, basically to make this foramen disappear. However, sometimes this foramen can remain patent and then can communicate with the TMJ. There was a recent paper in ASHNR which talked about association of this patent foramen of Husky and necrotizing otitis externa. So, so yeah, that's, I think our case is kind of interesting in that, on the right side, it was probably related to maybe trauma, but on the left side, de novo, development of a bony defect is kind of interesting. And, maybe it's just, she has TMJ arthritis. Maybe that's what it is, so. With that, I am going to pass the baton over to the awesome Amy Juliano, and she has a few, I think maybe companion cases. All right, take it away, Amy.
Okay, thank you, Gul. Let's see, I don't see too many questions here for Gul so far, so I'll continue and I will share my screen. I think first I have to get this up.
So while you're getting your screen up, I'll just read some of the comments. Sanjay Prabhu says, interesting that pediatric patients post-ECMO have not been included in the list. He notes that there's a higher incidence of deafness in these patients and wondering if hemorrhage could play a role as well. But of course, we don't usually image the kids during the acute phase, and even when we do, we don't typically even think of looking for labyrinthine hemorrhage.
Okay, so can you all hear me?
Yes, we can hear and see you.
Okay. All right. So just a follow-up from last week. We already tweeted these out a little bit, but these are two papers that we had mentioned a little bit last week. This one is by my colleague, Dr. Reinshagen, about the sclerotic phase of otospongiosis or otosclerosis. And the one below is a paper that we did put out about measuring the vestibular aqueduct. That's a follow-up to the Cincinnati and Boston criteria. Okay, and this is another follow-up from last week. There was a question last week about whether you can get labyrinthitis ossificans after cochlear implantation. And I think we have maybe some mass idea otologists on this conference, so I better be careful. But typically we don't image them, but if we do, looking at the contralateral side for implant or what have you, we don't usually see ossificans. But here's one case that I just discovered that shows a cochlear implant, and there is a bit of calcification. So it does happen, but we don't really see that too often, and it's not that confluent throughout the entire cochlea. So that's another follow-up. Okay, so for me, my first case today, 39-year-old male with chronic left otorrhea. Okay, so I saved a clip. So this is the left temporal bone in bone window. And as you scroll down, a bit of mastoid opacification, maybe just an effusion. We never use the word mastoiditis. And I think Katie is on this call and she agrees with me, trailer. Okay, so we see a bit of opacity in the middle ear cavity, lateral to the ossicles, and there's erosion of the adjacent bone margin. So let's keep going down, and there's more. There's more scalloping of the bone, continuing out from the area of the middle ear. And as we keep going down, all this area looks like someone took a bite out of it. So there is opacity. I always hesitate to say, as Callie referred to earlier too, whether it's fluid or soft tissue, because we just don't really know on CT that well. But for sure, there's opacity with associated bone erosion. It's bulging in, maybe that's in the external canal, and all the way down. And as we go down, we can see that there's a bit of bone change to the mandibular condyle. We'll save that in our back pocket to revisit again later. So going back up again, opacification of mastoids, no bone erosion. Really the action is in the middle ear, EAC, and towards the squamosal portion of the temporal bone with bone erosion that's quite sharp. And a bit of reactive bone changes here as well. Okay, we go to the coronal, and here we can see that bitten out bite, that big chunk that got taken out from bone erosion. We go forward, it's contiguous with the mandibular condyle. We keep going forward, it is in the middle ear, it's eating through the scutum a bit, and maybe it's bulging the tympanic membrane medially. Okay, so we're dealing with a space occupying mass with bone erosion, where the bone erosion has pretty crisp margins. Okay, so now we have soft tissue window. We don't look at soft tissue windows that much on CT, whether contrast enhanced or not, because we usually just move on to an MRI, and CT may be tricky. But here, since we have it, let's take a look. There is some heterogeneous density. Some areas look a little bit less dense, almost looking like it's fluid or edema, but some areas are a bit denser. Maybe it's enhanced, maybe it's intrinsically dense because this is non-contrast enhanced CT, and it's bulging out maybe a little bit towards the mascator space. Okay, so what is the differential diagnosis we have so far? A mass with bone erosion. It's extending out towards the squamosal portion of the temporal bone. And then on the coronals, we can see it's in the middle ear and external auditory canal with some expansion. So I think Phil Chapman did light up Twitter a little bit recently about opacity in the EAC with some bone scalloping. So in the differential, you could include keratosis obturans, especially if it's a smooth expansile scalloping, With a cholesteatoma, usually it should be a little bit ratty, a little bit irregular, because there's the perimatrix around the clump of keratin that generates some bone erosion, maybe enzymatic properties. So we could talk about keratosis obturans, maybe EAC cholesteatoma. Sometimes there's some overlap. This looks a bit irregular. So it's hard to know. What else? Well, we would like to include malignancies. So last week, I think I mentioned you always want to think about squamous cell carcinoma, maybe basal cell in the EAC. So that would be the differential. That's probably a good list. And then last week, there was a case of an LCH. Callie mentioned that also. Typically, that's centered at the mastoid. It's a little bit unusual anteriorly, but not impossible. The patient is sort of a young adult. Okay. So bulky mass like with bone destruction, we already talked about this. And then a necrotizing otitis externa, usually the soft tissue would go along the skull base, would insinuate the bottom, not so much anteriorly towards the squamosal portion of the temporal bone. And the bone erosion in the margin shouldn't be nearly as crisp. So this is a little bit like punched out lytic lesion with sharp margins and some periosteal reaction. So we mentioned Langerhans cell histiocytosis, and then punched out lesions, multiple myeloma, maybe metastasis. And then we move on to think, well, what if it's a primary bone lesion, like an aneurysmal bone cyst? You know, those things I think way back, I memorized sphygmomatic, things like that. So a bone, primarily bone issue, not so much a temporal bone related lesion primarily. But we have to think about how it is near the TMJ. And I promise I didn't coordinate with Gul, but you know, this is a lesion that is really causing some changes to the mandibular condyle, suggesting, well, what if it started in the region of the TMJ? So then you think about giant cell tumor, maybe pseudogout, some synovial tumors. All right, so then we move on to MRI because that helps us define what that soft tissue is. So again, I have these clips. So on this T2 weighted sequence, you're scrolling through, and we can see, look at how dark. This is a dark, big, bumpy, lumpy mass that's in the TMJ all the way around the condyle. It has mass effect, and clearly that is what is eroding and extending into the middle ear. So we're dealing now with something that's really centered at the TMJ, and it's very dark on T2. So dark on T2 could be calcifications, but we didn't see any on the CT. So another thing would be hemosiderin. So now let's take a look at this post-GAD T1, and we can see all this maybe reactive around the muscles, but really the mass is this hypo-intense looking lumpy, bumpy mass going up and even see eroding and really sharply scalloping out that squamosal portion of the temporal bone. And then we have some coronal clips, again, just showing how it is really dark and it is really centered at the TMJ and bulging everywhere, causing lytic chopped out bone erosion. And then on this post-GAD as well. Okay, so this is a case of a tenosynovial giant cell tumor, sometimes referred to as pigmented bilinodular synovitis. Some pathologists move away from that. If it's in one joint, they call it a tenosynovial giant cell tumor, but it's along the same spectrum. So it's proliferative. It's now considered maybe it's neoplastic potential, and it's from the synovial cell. So it's lining the joint, and it's proliferative, and there's hemosiderin. So there's mass effect, and there's this dark signal, and that's fairly characteristic. We've had a few cases of that, so let me show you a companion case. In this patient, it was on the right side. Look at, it's eating into the otic capsule, causing third window. It's eating into the area of the cochlea, so the apical turn is eroded into. The middle ear, you have lost all the margins of the middle ear cavity, the ossicular chain, there's a bite out of the head of the malleus, and all the anterior margin. But if you notice, going down, look at that scalloping and flattening of the mandibular condyle, suggesting this really is a big round thing coming from the TMJ and extending up. And then on the MR, you can see there's this black mass. Okay, so that's the take-home point of this case. It's really not sometimes so much about the diagnosis necessarily, because you can look online, you can do your research. It's about the thinking process. So we have a T-bone lytic mass. We have to know the differential diagnosis. So common things are cholesteatoma. In the EAC, we can invoke, maybe it could be keratosis obturans, and then bad cancers like squamous cell carcinoma of the EAC, and then some other masses, which Callie referred to as well. And then we look for help. is there bone erosion? If there is bone erosion, are the margins permeative? So for example, if it is, let's say a paraganglioma around the jugular foramen, that should never be crisp. That should be sort of washed out, permeative looking, smudgy. But if it's sharp, we would think about like LCH, multiple myeloma, or in this case, it's fairly sharp because there's a smooth scalloping by this mass effect. And then one thing really to remember is that we all talk about temporal bone, this is T-bone time, but lesions can come from elsewhere. So in this case, it's a TMJ lesion going into the temporal bone. You can have nasopharyngeal carcinomas that are extending directly and eroding into Petrous apex. That can happen through the foramen of Morgagni, through foramen lacerum. So it could be from adjacent stuff. Facial nerve, you can get a big schwannoma that's bulging into the middle ear. Jugular foramen, like the paraganglioma, can be bulging in, causing a jugular tympanicum going into the middle ear. So just to think about elsewhere, locations outside of the T-bone to see if that might be the origin. Okay, so that is my first case. And I think I'll move into my second case. This is a 36-year-old female with left facial paralysis. So again, I have the clip here. So as I'm scrolling down, mastoids look good. EAC looks good. So we go in, we go from out to in. We look at the tympanic membrane. We look at the middle ear cavity, looks pretty clear. Ossicular chain looks okay. We go through the different parts of the malleus incus stapes. And then we look at the inner ear. So the turns of the cochlea and so forth. Everything checks out pretty well until we get to the checklist for the facial nerve, which really leads us to this big elephant in the room. So we can see that even the labyrinthine portion is effaced. And there's this sort of bony calcific thing sitting right there, leading right into the geniculate portion of the facial nerve, but it's beyond that. It's kind of expansile going forward. And then it comes back again. So a little bit, the proximal portion of the tympanic segment of the facial nerve. So here we're dealing with an expansile lesion that seems to be centered or involving the geniculate region of the facial nerve and adjacent segments. And it's kind of bony, or at least it's mineralized with calcification. Okay, we go to the coronal clip, and again, we can follow it. So these are the two dots we usually look for with the facial nerves. So the labyrinthine tympanic segments, and they join in the front towards the geniculate, and that's where we see this expansile mineralized lesion. And it looks fairly extracranial. It doesn't seem like it's really going intracranial. Okay, so now let's look at MRI. So here is a post-GAD T1. So we're going to look for that lesion and see what it looks like. So here there is enhancement mixed in with some areas of signal dropout. So there are bone spicules, bone calcifications or mineralization, and some enhancement. And the enhancement is typically maybe more avid if there's less bone, but if there's all this bone, it's harder to see. And then this is the heavily T2-weighted sequence, again showing that lesion fairly dark and looking extracranial. Here is a coronal sequence, again showing that lesion, and the feature here really is that there's not really much dural enhancement. It's extracranial. It's not really intracranial, involving the dura much. Okay, so what is the differential diagnosis? So basically expansile mass involving the geniculate ganglion with calcifications and enhancement. So I just want to show a companion case because that is a little atypical. This is more usually what they look like. Expansile geniculate region, little specks of bone, and lots of enhancement. So one thing to consider, if there were not these little specks of calcification, would be a schwannoma. You can have a facial nerve schwannoma. That would be a great look for it. So is this a schwannoma? Well, with the bone specks, you really don't expect that, the speckled calcification. And this is in fact a geniculate region venous malformation. So in the past, this has been referred to as hemangioma or IBVT, intraosseous benign venous or vascular tumor, but really these are not tumors, these are not neoplasms, these are venous malformations, and that is the proper terminology for this lesion. So this is our case as well. This is a geniculate region venous malformation. So the features are intratumoral bone spicules, irregular and indistinct bone margins, and they're focal. So it's not going to be like skipped segmental along the entire length of the facial nerve like a schwannoma. It's going to be focal just at that location. Hyper intense on T2 and enhances, but if there's a lot of calcification, it may be hard to see. Okay,
So
so
Amy, a lot of chatter.
Oh,
Could
really?
you just say another word about the terminology? Because there's a lot of chatter in the chat box about the terminology.
Is Debbie Schatzkes on this call?
She isn't, but we're waging the war on her behalf.
Yes. So the Mulliken-Glowacki criteria came out of children's, at least, you know, in a large part, is really this division between what is considered tumor and not. So you can have vascular lesions. Vascular lesions are all types: high flow, low flow, hemangiomas, capillary hemangiomas, all different kinds. Those are all vascular, some element of blood related to it. But there's really histopathologically a classification between what is considered neoplastic and truly proliferative in a monoclonal way versus a malformative lesion. You're bored with it, things are formed in a little bit irregular way, and you develop, let's say, a lymphatic malformation or a veno-lymphatic malformation. So those are malformative lesions, not neoplastic lesions. And it's important to distinguish between the two. So in this situation, at the geniculate area, these are malformative lesions and these are venous malformations. Those you can see with phleboliths, like a lot of times in the parotid area, masseter area. So I'm not reading the chat, so I'm not sure what else there is to address. But we do take great care at Children's, where I trained as well with Callie, and at Mount Sinai to really make a distinguishing point between the two. Okay, so this is another case that looks very similar to the case that I showed. So the case that I showed is down here with a green frame. And here looks very similar, right? It's expansile, it's kind of lots of mineralization, geniculate area. But on the MR, this one you can see there's a lot of intracranial stuff going on. There's dural thickening and enhancement, and it looks bulky and mass-like, intracranial, but extraaxial, as opposed to our case, which was really confined to outside of the calvarium. And so this would be in the differential diagnosis. This is a meningioma where you can have an intraosseous component, or it's reactive and getting incited. Another companion case, it's expansile. It's in the region of the geniculate ganglion. But on MR, this follows CSF signal, and which is much more well clarified on the heavily T2-weighted sequence. It's CSF signal. So this is a meningocele. So that's the differential for geniculate region lesion, our venous malformation. You can have a schwannoma, a meningioma like the companion case that I showed, a cholesteatoma that can erode all the way towards the geniculate area, making it look like the geniculate is expansile, a meningoencephalocele, and very importantly, not to forget, is perineal spread of tumor, because you don't want to miss a malignancy, which would be, you know, bad and would delay care. So here's an example of a bad malignancy that is a poorly differentiated squamous cell carcinoma, likely a lot of times in the skin, extending to the parotid, and that one is spreading along the facial. But as you can see here, the whole course is widened and expansile. So whenever you see anything along the facial nerve, okay, think about schwannoma. Here, okay, think about venous malformation, but always check all the way downstream out the parotid, xylomastoid foramen and beyond to see if maybe you catch something that you don't want to miss. Okay, so those were my two cases, the PVNS or tenosynovial giant cell tumor and the geniculate region venous malformation. Thank you. So now I will pass the baton over to Felice Darko. He is in the UK and it's quite late there now. I will stop sharing and let Felice take over.
Thank you very much. Fantastic cases, really. So what I will try, oh no, I spoiled the animation. So what I would like to do now is an experiment. So I would like to do a quiz case. So I will show you, first of all, I will recap the two cases that I showed last time, because there were a lot of questions about that, those two cases. And then I will show you interesting case, and I will ask you to either write down in the comment what you think is the diagnosis, or tweet using the hashtag T-bone time. So last cases, I show you two cases, and the first one was this 7-year-old child with a genetic diagnosis of 3MC syndrome, and with this right here cholesteatoma on examination, but bilateral mixed hearing loss. So they asked for a CT, and first of all, I Googled it, the syndrome, because of course I had no idea what this was. This is due to a gene that's called MASP1. I'm showing you first the diagnosis because, of course, this is how the case came. And the interesting things when we deal with children with genetic diagnosis is that we have really a lot of association in the body. And these I found fascinating and very useful also for the diagnosis and the management of the children. So you really need to think of the association. It's not the gene diagnosis in this case that is important because we had already the diagnosis, but really the association. So this was the coronal CT. I showed you all the DICOM last time, but for the sake of time, I will just show this slide. And there was this small area of soft tissue density in the Prusak space with erosion of the scutum that is truncated. But because, and this is what they were looking at, they were the ENT, and this is a small cholesteatoma. However, because this is a genetic diagnosis and because the child had bilateral sensory hearing loss, we needed to keep looking. And as I showed you last time, there were these bilateral dysplasia, dysplastic appearance of the inner ear, characterized by this abnormality that we call persistent enlage of the lateral semicircular canal and the sharp lateral margin of the cochlea because the interscalar septum is absent. So there is an incomplete partition that we label as incomplete partition type 2. Plus, because we had the CT, we kept looking at it and we saw extensive veins in the skull base due to the fact that the child probably had craniosynostosis, although we just have the Petrous bone. And we confirmed with a coronal diffusion the fact that this was a cholesteatoma. So this was the case, and I'm showing you this because these two cases that I showed you last time are relevant for the quiz case I'm going to show you. So what I learned from this case, well, that you need to really look at the bigger picture, and this was very rare in case of 3MC syndrome. There was no description of the inner ear findings, so we published that. Why is that gone? Sorry. Okay, and then the second case I showed you is this very typical abnormality, again bilateral. So when you see bilateral and symmetric abnormality in the inner ear, think of genetic diagnosis. And you see that here we do see the interscalar septum. So the external profile of the cochlea is preserved, but we have very large internal auditory canal and no internal structure, so no modulus and probably a bit of lamina spiralis. So this is an incomplete partition that we call incomplete partition type 3. It's an X-linked deafness, and it's very, very important because we can do the genetic diagnosis, which is POU3F4 gene mutation in the vast majority of the cases. And we have this typical radiological phenotype. It's important, again, to look at the bigger picture and to look at the rest of the body. In this case, as I showed you, these are two different cases with the same mutation. There was this large mass in the hypothalamus in the case, in one cases, and this lumpy bumpy appearance of the hypothalamus in another child with the same mutation. So what we looked for when we did this observation is what is the genetic link between the hypothalamus and the incomplete partition type 3 and this kind of X-linked deafness. And looking at the literature, we found that actually this specific gene in the POU family also regulates the brain development, in particular the hypothalamus. So we explain the fact that we have in this patient a specific malformation. So you see something like that, you should be able to do a genetic diagnosis, but also the fact that we found this dysmorphic appearance of the hypothalamus. This is not a standard hypothalamic hamartoma and has a different management. Now, quiz time. So I cannot see the chat, but please feel free to say the diagnosis or to tweet the diagnosis. This was an 8-month-old female with bilateral sensory hearing loss and a history of neonatal gastrointestinal surgery. Nothing else specified in the request, as often happen. So let's see some images. 1 and 2. So, okay, so we have the CT and the 3D T2 MRI, and then I will show you some screenshots. So let's start with the screenshot of other part of the body. Again, because in these cases of genetic abnormality, we really need to connect the dots. And this is these are the appearance of the cochlea. Let me zoom it. So you can see, so we have the basal turn of the cochlea, we have the middle and the apical turn of the cochlea, we have the modulus, and we have the interscalar septum separating the gyre. However, the cochlea looks a bit flattened, looks smaller than it should be. So we see that this abnormality is subtle, but is there. And of course, the inner ear, they have a characteristic that they are developed at birth and they do not change in size apart from the vestibular aqueduct that can grow over time physiologically. So we can use, there are some papers on measurement, so we can use, I don't like measurement too much in radiology, but when you have a doubt, use the measurement. The important thing in this case is to look at the semicircular canal. So the lateral semicircular canal is not completely absent, completely fused as before. So there is not the so-called persistent enlage of the lateral semicircular canal, but is small. And the posterior is completely absent, and the superior is present, but possibly small as well. See here, very symmetrical abnormality with the semicircular canal absent here, a bit better the lateral, while here is probably smaller. But the thing really that was important for us in the discussion is how we call this cochlea. Now, I think that the best way to evaluate the cochlea is still the MR. So this is the 3D T2. And you can see that the basal turn is there, but basically we had the impression that both the middle turn and the apical turn were slightly smaller, and the modulus may be slightly underdeveloped. I will show you the comparison with the normal one. The nerves were there, as you can see here, and again you can see the relatively symmetric appearance of the semicircular canal with the absent posterior semicircular canal, but small lateral semicircular canal, at least on the right. So not exactly the same, because the lateral semicircular canal a bit better developed on the left, but still relatively symmetric abnormality. So we are looking to a genetic cause for that. Now, I describe this abnormality like dysplastic lateral semicircular canal right more than left, absent posterior semicircular canal, and cochlear hypoplasia type 3, which I confirm with the measurement, and the measurement you should do in coronal, and we can speak about that. So there is bilateral cochlear hypoplasia type 3. Now, let's see the other abnormalities. So this is a MIP, and you can see that this is quite small. And if you compare with the normal development of the modulus, you see this is a normal cochlea, the middle and the apical turn. Here they are present, modulus is there, but all the turns, they look a bit flattened, and the total size of the cochlea was smaller. So we decided that this was a cochlear hypoplasia, and we call it cochlear hypoplasia type 3, meaning that there is no incomplete partition, but the cochlea is small. So have a look to this image. I will not tell you what's wrong with that, but I'm telling you that there are two of these three images which show an abnormality. In particularly, something is missing in two of these images. I know that it's just a single image, but take a few seconds to have a look. In the meantime, I will... Okay, so we have a lot of things. So we have people speaking about bore, some people saying about Wardenburg, some people saying again bore, Alagil. Alagil, I have to say there is only one case report of inner ear abnormality in Alagil. So when we publish about syndromic causes of hearing loss, they say not put it out. Pendred, no, it's not pended, and I will tell you why it's not pended. Also, it's not charged because the appearance of charge is very specific, and it's not that. So Anna Geraldo say the olfactory bulbs and nerves are missing very well. So this is abnormal, and the olfactory bulbs are missing. Fine. Also, Rasan say the same. No, third nerve. Third nerve. How you can see the third nerve? No, anyway, I think was okay. It's not septoptic. Okay, very well. So Anna Gerard is crushing it because she also picked up that there is a parotid gland that is missing. That's very good. There is no parotid gland and no olfactory bulb, bilateral sensory hearing loss, and this is and this is really the important thing, especially because the child had an operation in the gastrointestinal system. So Anna and Ata and someone else, they are right. This is Wardenburg syndrome, and this is how it looked like. I understand very little about the radiographic appearance of Hirschsprung, but this is Hirschsprung. So we have Kalman, i.e. absence of the olfactory bulbs and nerves. We have Hirschsprung, we have deafness. This is a Wardenburg. But now, okay, so you name the condition. You told me why, on which you base your diagnosis, because of this combination of gastrointestinal findings, Kalman disease, so Hirschsprung, Kalman disease, absent parotid gland. Now you tell me the gene, because Wardenburg is quite wide, and of course, in this case, like for IP3 case, you can do not only a syndromic diagnosis, but also a precise genetic diagnosis. And this is very relevant, okay? So we have one answer, SOX10, okay. So yes, this is a SOX10 mutation due to, so this is a bilateral sensory hearing loss due to SOX10 mutation in Wardenburg syndrome, characterized by association between Kalman, sensory hearing loss, and Hirschsprung. I will show you again the images, and I want to show you also a couple of interesting references. So again, the images, remember the modulus is there. Remember that, at least this is my opinion, the modulus is better seen on MR, is underdeveloped, and especially the middle and apical turn are slightly irregular and flattened. But this is very, very, very subtle findings. And we think that this can be classified as type 3 cochlear hypoplasia. If you want to measure, use the coronal CT. And about the measurement, again, you will not be able, unless you do something very fancy, to measure all the cochlea. But in coronal, when you see the middle and apical turn, you should have at least 4.5 millimeters. This is smaller. Now, so this is what I use. And another thing, in order to measure this dysplastic lateral semicircular canal, it is very important that you measured the so-called bony island in axial, and Susan Blazer described in Down syndrome a lot of this dysplastic lateral semicircular canal, and the cutoff she found was 3 millimeters. So use measures, but with some, you know, it's not the gospel. And this is SOX10 mutation, cochlear hypoplasia type 3, absent posterior semicircular canal, dysplastic the other canal, with associated hypoaplastic olfactory bulbs and Hirschsprung disease. And if you want to look at a paper, this was a paper that we wrote on all the syndromic causes of hearing loss. This is a paper from France and Leuven also, clinician, regarding Waardenburg syndrome and SOX10 mutation with associated temporal bone abnormality that I found very helpful. And if you have other questions, I think I'm very happy to take them.
Great. Thanks so much to all of our panelists. And are there any other questions before we wrap up? Okay, do you measure the diameter of the bone island of the lateral semicircular canal? Yeah, I do. When it's obviously small, it's obviously small. And if there's doubt, you can measure it. And there are measurements that were published years ago by Dr. Lan. I still have that article. It provides measurements for a whole bunch of things, including the bone island. Small bone island, we think of a few syndromes in particular. Felice, as you mentioned, trisomy 21, also 22q11 deletion syndrome. There are rarely cases of charge syndrome where the canals are formed enough to have a small or absent bone island. And otherwise, it's a very non-specific anomaly. Felice, they want to know, do the cases with hypothalamic dysplasia have any hypothalamic dysfunction?
No, so that's the interesting thing. So these were basically asymptomatic. And so that's a mystery, but it's very important that when they are associated, they don't need operation like for hypothalamic hamartoma. So it's something different. We are not sure why, but they do not have hypothalamic dysfunction. So that's very important. I also wanted to say something about charge, that someone say that can be charged. It's very typical and shows no semicircular canal. While the boar will have this unwound cochlea, which looks like a clava, basically. So is quite different, the appearance, although can be classified within the cochlear hypoplasia type 3 or type 4, in the sense that incomplete partition, the partitioning is present. So you can see the lamina spiralis, you can see the interscalar septa. So is in the spectrum of cochlear hypoplasia, but it's not quite the same.
Couple other questions here. They want to know, Salima is asking, which axis do you use to measure cochlear height? Is it the axis perpendicular to ovale windows plane?
Yeah, it's perpendicular to oval window plane, and then actually there are some other measurement with some reformats, but actually I found it quite okay. So I don't need to do multiparametric reformat. But most of the cases with a bit of experience, you don't need measurement. I just used to convince my clinician, to be honest.
And then Sandeep's asking us about the ideal protocol for CPA inner ear imaging and MRI. And I think we would answer that by starting, it really depends on the clinical indication, and the protocol for kids and adults is quite different. So if you have a kid with congenital hearing loss, we will image them, really depends on the magnet that you have, but with 3D T2 weighted images, axial, and then we tend to acquire direct sagittal obliques at right angles to the plane of the cochlear nerve. We don't give contrast for kids with congenital hearing loss, it's just not indicated. Whereas obviously with any adult or kid with acquired hearing loss, those are the kids where you'll use a combination of the 3D T2 as well as contrast enhanced thin section high-res fat suppressed T1s. And then of course remember to get the AX T1s pre-contrast or flares. And some people also advocate, if you're interested in seeing if there's labyrinthine enhancement, that you may want to do flares post-GAD as being even more sensitive than the T1s. People are asking about recordings. We have, I think, successfully recorded this. We will actually have to figure out what to do with the enormous file that the recording generates, and also figure out a way to have our viewers be able to see it. This is not a CME event, this Q&A. I do also want to remind everybody that the ASHNR has its first live webinar tomorrow, formal didactic, kicking off with temporal bone anatomy. And that will be a CME event. You pre-register using the link provided by ASNR, also visible on Twitter. And those will definitely be recorded and housed on the educational forum of the ASNR website. All right, great. Thanks so much. We'll see you all in a couple weeks' time.
Thank you, everyone.
Thank you. Bye.
Bye. Thanks, everybody.